Hello my dear students, today I am going to elaborate three basic and important topics of cardiovascular pharmacology that includes the introduction to the cardiac electrophysiology and the pharmacology of drugs used to treat congestive heart failure and angina pectoris. Now coming to the very first topic, that is the cardiac electrophysiology. Uh, in the cardiac electrophysiology, we are going to study four basic characteristic features related to the electrical impulse generation and conduction in the heart or myocardial fibers. So the first uh, characteristic feature related to the cardiovascular pharmacology is impulse generation. So in impulse generation, basically in the myocardial fiber, there are basically two types of fibers: non-automatic fibers and automatic fibers. So in non-automatic fibers, they are basically ordinary working myocardial fibers, and they cannot generate impulse of their own. And the automatic fibers such as SA node, AP node, and His Purkinje system, they can generate their own impulses. So these non-automatic fiber, automatic fibers basically differ in the automaticity or generation of impulse. So non-automatic fiber. So they are basically ordinary working myocardial fiber, and they can generate an impulse on their own. So there are basically four phases of impulse generation. So during diastole, the resting membrane potential remains stable, and it is about 90 millivolt negative. And when the action potential or stimulation occurs of non-automatic fibers, then it gets depolarized very rapidly or very fastly, and it is this depolarization phase called as phase 0, and which is followed by the considerable overshoot of about plus 30 millivolt. Means from minus 90 millivolt the impulse rises up to plus 30 millivolt, and then it gradually returns to the isoelectric level, and that is called as phase 1. And the isoelectric level means when the net charge is or net impulse is about 0, and at that level the membrane potential is maintained for a considerable period of time, in which the calcium ion inflow occurs inside the cell to bring about the contraction, and that phase called as phase 2 or plateau phase, which is followed by the relative rapid repolarization of the myocardial cells membrane, and that is called as phase 3, in which the ion balance is get restored by the activation of sodium potassium multiphase pump, and it leads to the normalization of the ion balance, and it brings down the membrane potential to the resting condition. And once the resting membrane potential once attained, then it does not decay, and that phase is called as phase 4. So in non-attractive fibers, phase 0, that is the depolarization, which is followed by the phase 1, in which there is a rapid return to the isoelectric level, followed by the phase 2, in which there is a calcium intake, and then the repolarization in the phase 3, and phase 4 there is a resting membrane potential attained around opening of the great veins. Okay, so the most characteristic feature of these fiber is the phase 4 of slow diastolic depolarization. So the automatic fiber and non-automatic fiber basically differ in the phase 4. In automatic fiber, the phase 4 in phase 4 there is a slow diastolic depolarization. Means after repolarization to the maximum value, the membrane potential spontaneously decays. It means that the sodium channel gradually opened, and there is a slight and slow intake of the sodium ions inside the myocardial cells, and when this that brings about the stimulation or impulse generation inside the myocardial cell, in automatic myocardial cell, and when it reaches to the critical threshold value, the sudden depolarization occurs, and all the three phases from 0, 1, 2, 3, and 4 get followed. And when again when the phase 4 is attained, then again it gradually decays, and it automatically brings about the depolarization when it reaches to the critical threshold value. So in this way, what we can see is that the automatic fiber, there is automatic generation of impulse. No external stimulus or depolarization from any other cell or from system is required in automatic fibers. That's why they are called as the electricity generator of the heart. So and the rate of impulse generation by particular fiber depend on the three factors. First is maximal diastolic potential, the slope of phase 4 depolarization, and the value of threshold potential. So in this figure you can see In phase 0, there is a fast upstroke, there is sodium intake that brings about the rapid depolarization, which is followed by the blockade of sodium intake and the potassium outflow in the phase 1 when there is a partial depolarization occurs. In phase 2, as I already said in the previous section, that the calcium intake occurs and the potassium outflow is also there, and in the phase 3 the potassium outflow occurs and the calcium intake is blocked, and then the sodium potassium ion balance is get restored through the sodium potassium ATPase activation, and in the phase 4 the membrane potential resting membrane potential is attained. So now coming to the second characteristic feature of the electricity generation in the heart is conduction of impulse. So this is the rate of conduction is defined by the rate of rise of action potential. Means in a particular time period, how much action potential or how much potential is attained by a particular myocardial cell determines the rate of rise of action potential, or we can say the rate of conduction. So basically in small cells, the upper margin of every node have very low conduction velocity, about 20 mm per second, and in Purkinje fibers have their high conduction velocity of about 4000 mm per second. Now coming to the third feature, that is excitability. It is defined as the strength of stimulus required to produce response or to produce an action potential in the particular myocardial cell or myocardial fiber. And the last one is the refractive period. The effective refractive period is the minimum interval of time between two propagating action potentials. It is basically the minimum interval of time between the two propagating action potentials. So these are the four characteristic features related to the cardiac electrophysiology. Now we are coming to the our second topic, that is the pharmacology of drug used to treat the congestive heart failure. So now coming to the what is congestive heart failure. So congestive heart failure is basically complex progressive disorder in which the heart is unable to pump sufficient blood to meet the need of the body. So its cardinal symptoms are dyspnea, fatigue, and fluid retention. These are the basic three basic symptoms of the CHF. So in high heart failure, there is an impaired ability of the heart to adequately fill with or reject blood. In the ability of the heart to adequately fill or reject blood is got impaired in heart failure. The underlying causes of the heart failure includes there are various causes like arteriosclerotic or atherosclerotic heart disease, myocardial infarction, hypertensive heart diseases, or defects in valve of the heart like valvular heart diseases, dilated cardiomyopathy, or congenital heart diseases. So these are the conditions that states the congestive heart failure condition in which the ability of the heart to adequately fill or eject blood got impaired, and there are three basic symptoms of the congestive heart failure that are dyspnea, fatigue, and fluid retention. Now coming to the drugs used to treat congestive heart failure. So basically there are 7 classes of drugs that are used to treat congestive heart failure. The first is in renin-angiotensin system blockers. First is ACE inhibitors, that includes captopril, enalapril, fosmanogepri, lisinopril, pamipril. Second class is angiotensin receptor blockers. It is ARBs, that includes candesartan, losartan, valsartan, telmisartan. And the third class is beta blocker, in which the etinoprolol, carbidopa, and metoprolol are basically used. In diuretics, furosemide, hydrochlorothiazide, butyronide are used, and diactic vasodilators, especially hydrogen and sorbitinitrate, sodium nitrosides are used, and aldosterone interferon, spironolactone are used. And the important class that is basically confined to the congestive heart failure is the inotropic agents, that include the cardiac glycosides like digoxin, and the cardiac stimulants like dobutamine, and the phosphodiesterase inhibitor like ambrinolone and milrinone. So all other classes except this inotropic agent we are going to study in antihypertensive or anti-angina and other classes, but these class of drugs, inotropic agents, are specifically confined to the congestive heart failure. So basically we are going to study drug used to treat CHF, this class, inotropic agents class. Now firstly coming to the cardiac glycosides in inotropic agents. So these are glycosytic drugs with cardiac inotropic property. Inotropic means cardiac contractility property. So it what cardiac glycoside does to the heart, it basically increases the myocardial contractility or contractility of the myocardial muscles, and in and that leads to the increase in output of the hypotomic heart without proportional increase in oxygen consumption and heart rate. Um, they differ from cardiac stimulants like adrenaline and theophylline. They also increase the cardiac contractility, but along with that, they increase oxygen consumption and heart rate. And cardiac stimulants have short-lived action, whereas cardiac glycoside has prolonged action. So cardiac glycoside and cardiac stimulant basically differs in three features, and that both increase cardiac contractility, but cardiac stimulants also increases oxygen consumption and heart rate, but cardiac glycoside don't increase either oxygen consumption or either heart rate, and cardiac stimulants have the short-lived action, while cardiac glycoside have prolonged or long action. You know, cardiac glycosides are classified on in natural glycosides and synthetic categories. Natural glycosides are categorized depending on their biological sources. Distylis purpura leaf, the basic glycosides obtained from Distylis purpura leaf are distoxin, getoxin, getaline. From Distylis lanata leaf, as you can see here, are ditoxin, getoxin, and digoxin. From Strophanthus gratus leaf, strophanthine G is obtained. From Araginia, from Scilla bulb and Maritima bulb, Procelaridine A is obtained. From Thibetian nervula, Thibetians are obtained. From Convaluria majalis, convalutoxin are obtained. From Buffolgoids, that is from toad skin, bufotoxins are obtained. In semi-synthetic category, we have acetyl digoxin. Now, coming to the chemistry of cardiac glycosides. So, all glycostic drugs contain an A-glycone moiety, to which one or more sugar moiety, that is basically either glucose or distoxos, are attached to the oxygen molecule. The pharmacological action of the cardiac glycoside is due to the A-glycone or genin moiety, and the attached sugar basically modify the solubility and cellular permeability. What is A-glycone? So, A-glycone is basically the cyclopentanoperhydrophenanthrin nucleus, through which the unsaturated lactone rings, 5-member or 6-member unsaturated lactone rings, are attached. As here you can see in this figure, in cardiac glycoside, the steroid nucleus or cyclopentanoperhydrophenanthrin nucleus, through which unsaturated lactone ring is attached. So this is whole, and this whole moiety is the aglycogen part, and it is through oxygen group, it is attached to the sugar. So along with sugar, this aglycogen form the cardiac glycoside. Uh, in cardiac glycoside, on this 12th position, there is an attachment of one more hydroxyl group. So attachment of this hydroxyl group increases the polarity of the cardiac glycosides. For example, in digoxin, there is more hydroxyl group on the 12th position when compared to the digoxin, in which there is a hydrogen atom at this position. That makes the digoxin more polar compared to the digoxin. Now coming to the mechanism. In mechanism of the cardiac glycoside, basically there is deactivation of sodium potassium ATPase pump on the myocardial muscle cell. Like diastolis, what it does is it binds to the sodium potassium ATPase at the potassium binding site on the extracellular side, and it produces competitive antagonism for potassium at the sodium potassium ATPase. That leads to the decreased intake of the potassium ion inside the cell, and as we are seeing that it is antipode type of ion channel. So if there is a decrease in the potassium intake, then it leads to the decreased outflow of sodium ion consecutively. So that causes this increase concentration of sodium ion inside the cell, and it brings down the concentration gradient for the sodium intake by the sodium calcium exchanges. So what happens is that when there is increased concentration of sodium inside the cell, so then it leads to the decreased concentration gradient of sodium uh, inside for movement of sodium inside the cell, and it ultimately brings down the outflow of calcium through sodium calcium exchange, as it is also an antipode type of system. So what happens is through the deactivation of sodium potassium ATPase by dialysis or any other cardiac glycoside, it ultimately and indirectly leads to the deactivation of sodium calcium exchanger, and this deactivation of sodium calcium exchanger leads to increased intracellular concentration of calcium ion, and that free calcium ion uh, leads to increase in the in cytoplasmic concentration of calcium through more release of calcium from the intercellular stores, and that calcium along with actin myosin complexation brings about the contraction of the myocardial cell, and in that way it increases the contractility of the myocardial fibers or muscle cells. What happens is, firstly it increases the myocardial muscle cells contractility, and that leads to the uh, uh, increased ejection fraction from the heart, and increased ejection fraction leads to the decrease of sympathetic outflow, and decreased sympathetic outflow leads to the decrease in peripheral resistance and heart rate, and along with that parasympathetic activity through vagal nerves are also increased, and that also brings down the heart rate. So these cardiac glycoside along with increase in cardiac contractility decreases peripheral resistance and heart rate. Now coming to the pharmacological actions of the cardiac glycoside. Now firstly coming to the its action on heart. Force of contraction. First is force of contraction. So diastasis causes dose dependent increase in force of contraction of a heart, means it produces positive inotropic action. In failing a heart, it leads to the increase in cardiac output. In normal heart, also diastasis increases the force of contraction, but it will not get translated to the increased cardiac output. It will increase cardiac output through increase in positive inotropic action only in the uh, heart failure condition. Now, second is the heart rate. Heart rate is decreased by diastasis, as I already said, and bradycardia is more marked in CHF patient, and improved circulation uh, due to positive inotropic action restores the diminished vagal tone and also the sympathetic overactivity. So the basic reason for the decrease in heart rate is increase in vagal tone and decrease in sympathetic overactivity. And then coming to action on the blood vessels, so diastasis has mild vasoconstrictor action on and it leads to the peripheral resistance in normal individuals. So in normal individuals, there is slight increase in peripheral resistance through vasoconstriction by cardiac glycoside. But in CHF patient, as already said, there is a decreased sympathetic activity and increased vagal activity. So that there is a net decrease in peripheral resistance in CHF patient. So there is a opposite action on both type of person. In normal individual, there is a increase in peripheral resistance, but in CHF patient, there is a decrease in peripheral resistance by cardiac glycosides. Now coming to the next organ, that is kidney. Diuresis is seen in CHF patient. The retained salt and water are gradually excreted, but in no diuresis is seen in normal individuals or patients with edema. And lastly, on the CNS, higher doses causes chemoreceptor trigger zone activation that leads to the nausea and vomiting. Still higher dose produces hyperapnea, central sympathetic stimulation, and mental confusion, along with disorientation and visual disturbances. Now coming to the pharmacokinetic properties of the cardiac glycosides. So in this figure, we are comparing the pharmacokinetic properties of digoxin and digoxin. The oral absorption of digoxin is very good, and there is about 90 to 100% oral absorption for digoxin, and for digoxin it is good. There's about it ranges from 60 to 80%. The plasma protein binding of digoxin is very less, 25%, and digoxin 95%. That makes the volume better volume of distribution of digoxin as compared to digoxin. The onset of action of digoxin ranges from half an hour to 2 hours, and for digoxin it ranges from 15 to 30 minutes. The peak action was obtained from 6 to 12 hours, and for digoxin, and for digoxin 2 to 5 hours. And the duration of action for digoxin ranges from 2 to 3 weeks, and for digoxin ranges from 2 to 6 days. The plasma half-life of digoxin is 5 to 7 days, but of digoxin is 40 hours. And the route of elimination for the digoxin is through hepatic metabolism, and through in feces, and for digoxin it is from renal route. And administration for digoxin are administered through oral route, and digoxin administered through oral and IV both routes. So these are some characteristic features of the pharmacokinetic properties of digoxin and digoxin. Now coming to therapeutic uses. The basic therapeutic use of the cardiac glycoside is in the treatment of congestive heart failure. Along with that, it is also used in the treatment of severe left ventricular systolic dysfunction. and also in atrial flutter fibrillation, and in paroxysmal supraventricular tachycardia. Adverse effect, like cardiac adverse effect of the cardiac glycoside is atrial arrhythmia, and the GI adverse effect includes anorexia, nausea, and vomiting. In CNS adverse effects, there is a headache, fatigue, confusion, blurred vision, alteration of color perception. And one point that is to be noted regarding the adverse effect of cardiac glycoside is that diastolic toxicity results in ventricular tachycardia that requires administration of antiarrhythmic drugs or use of antibodies such as deoxyimmunotherapy. Now coming to the precaution contraindication. In hypokalemic condition, cardiac glycosides are contraindicated because hypokalemic condition there is a decrease in potassium. So the competitive antagonism of the potassium with the diastasis is get reduced. So that brings down more effective antagonism of the sodium potassium interface, because there is an inability of potassium, and in the scarcity of the potassium, there are more chances for the diastasis to more strongly and more prominently bind with the sodium potassium interface. So it brings about more prominent contractile action on the myocardial fibers. So in hypokalemic condition, it is contraindicated. In elderly person and in the person that are suffering from renal and severe hepatic disease, it is also contraindicated. In myocardial infarction patients, that are also contraindicated because it increases the cardiac contractility and cardiac workload. And in MI, it is a reduced oxygen supply, so it can precipitate more severe MI in patients. So it is contraindicated in MI also. In thyrotoxicosis, it reduces responsiveness to the diastasis, and in also contraindicated in ventricular tachycardia. Now going to interaction. Some diuretics like hydrochlorothiazide causes hypokalemia, which can precipitate diastasis arrhythmia. Because as I already said, the hypokalemic condition leads to the precipitation of more severe action of the diastasis. So in that condition, it precipitates severe diastasis arrhythmia, and for the treatment of this condition, potassium supplementation is required. Along with calcium, as calcium is already involved in the mechanism of cardiac glycosides, it is responsible for increasing the contractility and producing the prominent inotropic action. So calcium produces synergistic action along with diastasis, and it can precipitate toxicity. That's why there is a severe interaction with calcium also. Some drugs like quinidine, verapamil, diltiazem, captopril, and amiodarone increases plasma concentration of digoxin and through reduction of their excretion, and can precipitate diastasis toxicity. Some adrenergic drugs induces arrhythmia in diastasis patient. It is all about the cardiac glycosides. So other two classes are the cardiac in which there is dobutamine, that also increases the cardiac contractility through action on its beta 1 receptor, that is basically beta 1 adrenergic receptor, and through stimulation of beta 1 adrenergic receptor, and dobutamine increases the cardiac inotropic activity. And the third class is the phosphodiesterase inhibitor, in which there is two drugs, amrinone and mimrinone, and inhibition of phosphodiesterase leads to increased CMP level, and increased CMP level leads to increased interaction of calcium with the actin myosin fibers, and it leads to increased myocardial contractility. So again, it also increases the myocardial contractility. So these three classes, cardiac glycosides, cardiac stimulants, and phosphodiesterase inhibitors, these three classes are acting as a cardiac inotropic agent, and specifically used in congestive heart failure. Now coming to our third topic, that is the pharmacology of anti-anginal drugs. Firstly, coming to the angina pectoris. So angina pectoris is a severe cardiovascular disorder in which there is a characteristic sudden severe pressing chest pain that radiates to the neck, jaw, back, and arm. It basically occurs when coronary blood flow is sufficient to meet the oxygen demand or the blood demand of the myocardial system, and there is imbalance between the oxygen or blood supply and the oxygen or blood demand by the myocardial system, and that precipitates the ischemic condition. The This imbalance between the oxygen delivery and utilization results and get precipitated during the stress conditions like in exercise or in the blood vessel obstruction or from the spasm of vascular smooth muscle or emotional stress condition. So these are the conditions that precipitates the ischemic condition when there is an imbalance between the oxygen supply and delivery in the myocardial system through coronary blood flow, and it brings down the symptoms of the angina pectoris that basically include the sudden severe pressing chest pain that reaches to the neck, jaw, back, and arms of the body. Now coming to types of angina. So angina are basically classified into three categories. First is stable, typical, or classical angina. It is the basic form of angina and most commonly occurs. That's why it is called as typical or classical angina. In this type of angina, there is a coronary obstruction through atherosclerotic plug, and that leads to the decreased coronary blood flow, and there's imbalance between the oxygen supply and demand in the myocardial system. And when there's a stress condition like as already said in exercise or spasm or in emotional stress condition, there's a are more chances that it get precipitated into the angina pectoris. And this type of angina are basically relieved either through rest or through the uptake of the glycerol diethyl or GTN or because nitroglycerin tablets. Second class is unstable angina. Unstable angina basically falls between the stable angina and myocardial infarction. And in this type of angina, there is an increased frequency and are precipitated by less effort. And this type of angina are not relieved by the either through nitroglycerin or through rest, and it requires immediate hospitalization to prevent death or myocardial infarction. Now, third type is the premetal variant or vasospastic angina. It basically occurs at rest and is due to the coronary artery spasm, and it is due to unknown reason. So, in this figure here, you can see the conducting vessels and resistance vessels. Conducting vessels are the vessels that in those walls there is elastin and fibers, and there is increase in lumen size when there is an increased blood flow in this type of cells. But in resistance vessel, there is basically restriction of blood, and that's why it is called a resistance vessel. So in both type of vessels, there you can see in the resting condition exercise, in exercise during exercise or increased physical activity condition, there is increased blood flow in both types of vessels. But in classical angina, due to atherosclerotic plug, there the blood flow cannot be increased, and it compromises the oxygen demand that leads to the ischemic condition. And in the variant angina, there is a sudden spasm of the blood vessels during resting condition due to unknown reasons, and so the it is all about the types of angina. Now coming to the anti-anginal drugs. There are basically four classes of anti-anginal drugs. The first is nitrates, that includes short acting and glycerol nitrate or nitroglycerin is the short acting nitrate, and in long acting category there are sorbate dinitrate, sorbate mononitrate, tetranitrate, pentoxide tetranitrate. Second class is the beta blocker. Beta blocker basically propranolol, the non-selective beta blocker, and the selective beta 1 blocker, that is metoprolol, are used. And calcium channel blockers like phenylkymine and phenylamine category, where formula is used. In benzodiazepine, diltiazem is used, and in dihydropyridines, nifedipine, felodipine, amlodipine, and nimodipines are used. And the fourth category is potassium channel. Potassium channel, nicorandil and phenylketonuria are used. Some other drugs are also used in as anti-angina drugs, and that are basically dipheridamole, renologine, oxyfedrine. So it is in the pharmacological classification. So clinically, if the drug is used to abort, terminate the attack, so in that category, basically GTN or sorbate dinitrate sublingual are used. And if it is if there is are used for the chronic prophylaxis, then all other drugs are used. So it is about the classification of the anti-anginal drugs. Now coming to the first category, that is the organic nitrates. So organic nitrates are basically the nitric and nitrous acid esters of the glycerol. Now coming to the mechanism of the organic nitrates. So organic nitrates, when taken, firstly converted into the nitrate ion, and these nitrate ion get converted into the nitric oxide. Here in this figure you can see these nitric oxide enter inside the uh, vascular endothelium, and inside the vascular endothelium it activates the uh, guanosine adenosine guanylate cyclase. Sorry, guanylate cyclase. It activates the guanylate cyclase that leads to the conversion of GTP into the cGMP or cyclic guanosine monophosphate. When there is an increased level of cyclic guanosine monophosphate, then it acts through two prominent actions. The first action is the blockade of calcium channel, that is voltage sensitive calcium channel, and along with that it reduces the activation of MLCK, that is myosin light chain kinase, through its phosphorylation. When there is a reduced phosphorylation of MLCK, and that is active form of MLCK, then it is unable to activate the myosin into myosin phosphorylated form, and it is unable to bind with actin and produce contraction. Uh, and the second action is the blockade of calcium channel. So if there is a blockade of voltage sensitive calcium channel, then there is a reduced intracellular concentration of calcium, and this reduced intracellular calcium is unable to release more stored calcium inside the cell, and if there is a scarcity of calcium inside the cell, then it is unable to bind the calmodulin complex, and if there is a reduced calcium calmodulin complex, then it is again going to hinder the myosin and actin complexation, and again inhibiting the contraction. So in this both ways, the nitric oxide through the activation of guanylate cyclase produces the relaxation of the vascular endothelium or vascular smooth muscle cells, and increases the coronary artery lumen size or the blood flow or oxygen supply. So in that way, organic nitrates are basically increasing the oxygen supply inside the myocardial system, and making the balance between the oxygen supply and demand, and relieving the symptoms of ischemia or angina. Now coming to the pharmacokinetics of the organic nitrates. So for GTN, the onset of action ranges from 1 minute, and for monohydrate, it ranges from more than 1 hour. The first pass metabolism of GTN occurs in liver, and therefore it is taken to sublingual route or by transdermal patch. Oral isosorbate dinitrate undergo denitration to 2 mononitrates, and both have the anti-anginal activity. So these are the some characteristic features related to the organic nitrates. Now coming to the adverse effect, the basic and prominent adverse effect of organic nitrate include facial flushing, tachycardia, and hypotension, and therapeutic use. Talking to therapeutic use, and the basic use, as we are studying the angina pectoris, is the major cardiovascular disorder in which the organic nitrates are used. Along with that, they are also used in myocardial infarction, heart failure, and in acute coronary syndrome, esophageal spasm, and sinus. Pharmacological interaction. So with sildenafil and vasodilators, it produces dangerous hypertension. How? As we know, sildenafil are phosphodiesterase inhibitors. So if there is inhibition of phosphodiesterase, then there is an increased level of cyclic guanosine monophosphate, and if there is an increased level of cGMP, then it produces more inhibition of MLCK activation and no reduction of calcium inside the cell, and will ultimately lead to prominent vasodilation along with the organic nitrate. So if there is organic nitrate, then sildenafil will produce synergistic effect uh, with that, and can produce dangerous hypertension in this case. And so that's why the vasodilator also producing the vasodilation, and along with that organic nitrates, it will also produce the dangerous hypertension. So these two drugs are contraindicated along with the organic nitrates. Now coming to the second category, that is beta blocker. Beta blockers basically reduces the cardiac activity and reduces the oxygen demand by reducing both the chronotropy, that is heart rate, and the contractility, that is entropy of the heart. So by reducing the heart contractility and heart rate both, these beta adrenergic blockers reduces the oxygen demand by the myocardial system. And how they do that? They suppress this myocardial activity by blocking the beta 1 specific beta 1 adrenergic receptor that are basically present in the heart myocardial muscle cells. So there are basically three beta blockers are used in this category, and that are propranolol, metoprolol, and atenolol. Propranolol is less used because it is non-selective non-selective beta blocker, and it can also bring down the spasm of bronchial smooth muscle. That's why they are contraindicated in the COPD of COPD and asthma, and metaprolol, atenolol are specifically used, but at higher dose, all are non-selective beta blockers. So the dose adjustment and monitoring is also required to produce prominent action in the treatment of angina pectoris through beta blockers. Now coming to therapeutic use of the beta blocker, they are basically used in unstable angina or non-ST elevation MI, that is also called NST-MI. And there is a contraindication for the beta blockers in asthma, in COPD, in diabetes, in severe bradycardia and peripheral vascular diseases. The third category is potassium channel opener. As we know that if there is an opening of potassium channel, then there is always movement of potassium ion from inside to the outside of the cell. Means there is extracellular movement of potassium ion that leads to the, or that brings about the hyperpolarization on the membrane, on the cellular membrane, because of the reduction of potassium ion or positively charged ion inside the cell. So in that way it brings down hyperpolarization, and that leads to the relaxation of vascular or visceral smooth muscles. So in that way the smooth muscles are getting relaxed of the coronary artery, and that leads to the increase in oxygen supply or blood supply, and maintaining the imbalance between the oxygen supply and demand, and reduces the ischemic condition. So potassium channel openers also comes in the category of drugs that increases the oxygen or blood supply in the myocardial system by increasing the lumen size of the coronary artery through potassium channel opening and hyperpolarization of the vascular smooth muscle cells. The therapeutic use of potassium channel openers are in stable angina, in vasospastic angina, in hypertension, myocardial infarction, alopecia, bronchoasthma, and also in peripheral vascular diseases. Some serious side effects that are related to potassium channel openers are flushing, palpitation, weakness, headache, dizziness, and some other adverse effects are nausea, vomiting, and mouth ulcers. Now coming to the fourth and last prominent class of the anti-anginal drugs is the calcium channel blocker. So how calcium channel blocker act? They basically act on the voltage sensitive L-type calcium channel, and it produces its blockade. So calcium channel are basically of three types: L, T, and N type. T and N type are present in the brain and other organs of the central nervous system, and L type are basically present in the heart and the vascular smooth muscle cells. So by the blockade of L type calcium channel, these calcium channel blocker produces its prominent action in smooth muscle cell of the blood vessel and also in the heart. So how it produces its action in smooth muscle cells? So as we can see, in a smooth muscle cell it produces the blockade of voltage sensitive L-type calcium channel that leads to the, as already explained in the earlier section, that it leads to the reduced intracellular calcium that also inhibit the stored calcium release inside the cytoplasm, and if there is a reduced level of calcium, and then there is a reduced binding of calcium calmodulin, and this calcium calmodulin complex inability of there is inability of this calcium calmodulin complex in producing the myosin phosphorylation and activation by active binding, and that ultimately leads to reduced contractility inside the vascular smooth muscle cells that brings about the relaxation of the blood vessel and increases the blood supply. Calcium channel blocker acting on the heart. So in heart they are also reducing the calcium ion concentration inside the cell, and that leads to reduction of release of calcium from the sarcoplasmic reticulum, and that reduced calcium concentration is unable to bind with troponin, and if there is a reduced binding of calcium with troponin, then there is a reduced interaction of myosin and actin, and there is a reduced contraction of the myocardial fibers. So in that way, by deactivation of this voltage sensitive L-type calcium channel in the heart, there is a reduced cardiac contractility, reducing the cardiac workload, and in the vascular smooth muscle cells there is a reduction of contractility that leads to the relaxation of blood vessel and increase in oxygen supply and blood supply. So how calcium blocker acting? They are acting on both ways. All other drugs like organoids are acting by increasing the oxygen supply, beta blocker acting by reducing the oxygen demand, and again potassium channel opener acting by reducing the uh, increasing the oxygen supply. But the calcium channel blockers are acting in both ways by reducing the oxygen demand and increasing the oxygen supply. The very first class, that is phenylcalamine, that is the verapamil, it basically produces more negative nootropic action. Means it reduces the cardiac workload and more, and its vasodilation action is lesser. Means the oxygen supply, uh, increase in oxygen supply is lesser by verapamil, but the reduction in oxygen demand is more by the verapamil. So the basic adverse effects of the verapamil are nausea, constipation, bradycardia, congestive heart failure, and cardiac arrest on IV injection. So there are some interactions for verapamil with the beta blocker and cardiac depressant like quinidine disulfiramide. As I already said, in the myocardial system, it produces the severe depression of the myocardial activity. So it is contraindicated with beta blockers and cardiac depressants, and it also increases the plasma digoxin level by reducing its excretion, as we had seen in the cardiac glycosides class. So these drugs are contraindicated with the verapamil. And second class was the benzodiazepines, in which the diltiazem comes. Diltiazem's mechanism and pharmacological action is exactly similar to that of the verapamil. Means it also acts through decrease in cardiac workload and lesser increase in oxygen supply. And the third class is nifedipine. Nifedipine action is opposite to that of diltiazem and verapamil, and they basically focus on increasing the vasodilatory action or increasing the oxygen supply, and there's a very less reduction in the cardiac workload. And the adverse effect of nifedipine include the palpitation, flushing, ankle edema, hypotension, headache, drowsiness, nausea, increased urine voiding in elderly patients specifically, and in reduced insulin release. And now coming to the therapeutic uses of the all the three class of calcium channel blocker, and they are basically used in angina pectoris, in also in hypertension, cardiac arrhythmia, hypertrophic cardiomyopathy, and some specific drugs like verapamil are also used in migraine and leg cramps, and nifedipine is used in premature labor. In premature labor. So these are the four classes of the anti-angina drugs, that are the organic nitrates, beta blockers, potassium channel opener, and calcium channel blockers. So today we covered all the three topics related to the cardiovascular pharmacology. The first one was the electrophysiology of the cardiovascular system. Second was the cardiac glycosides that was used for that is basically used for the treatment of congestive heart failure, and the third is the angina pectoris and the anti-angina drugs. Thank you, students.